And you?
So I'm okay. So may I start? So we already have time.
Yes, please.
So if you can
I share my screen?
Time for the question and answer.
Okay.
So we have to finish within 1 hour. So at first I like to introduce you. So it is our great pleasure to have Professor Rajat Gupta in this keynote speech. He is a director of the multidisciplinary Oxford Institute for the Sustainable Development and the Low Carbon Building Research Group at Oxford Brookes University, UK. He holds a senior professorial chair in the Sustainable Architecture and Climate Change. Rajat's research interests lie in evaluating building performance from a socio-technical perspective, smart local energy system, local energy mapping, scaling of energy retrofit, and climate change adaptation. As a principal investigator, he has won over £13 million in research grant to investigate this subject. Rajat has been appointed as a secretary of the International Passive and Low Energy Architecture Network. He is also an appointed member of the UK government's Air Quality Expert Group. Rajat has delivered 50 conference keynotes and produced over 150 publications. So I would like to request his keynote speech. So please start.
Thank you, Home, for inviting me, and thank you to the conference organizers for inviting me to give a keynote. I'm just going to share my screen now. Home, could you confirm that you can see the slide mode?
Yeah, now it's okay. Yeah, it looks fine here.
Okay. Do we need to record this, or is it? Can I just proceed?
It's already automatic. It's already recorded here. So please start it.
Okay. Thank you, Home, for the introduction, and good morning, everybody. I'm at 7 o'clock here, but it might not be morning in many places. So good day to other people. So what I'm going to do in this keynote is, touch on an area which I think hasn't really received that much attention, and really needs attention now, given the urgency that we are in. An area where we don't talk about, that's why I've kind of titled this as "Do Old People Only Feel the Cold?" Which we do know about it. There is also the other half, which is the overheating and the elevated temperatures that they experience, especially during summertime. This is obviously a big issue because we have a warming climate rapidly happening. We also have an aging society happening, and obviously there's the ongoing pandemic. So all of these kind of big global challenges exacerbate this issue. So I've posed a few research questions, about 5 research questions that I would like to address through this talk. The first is, why is summertime overheating a serious issue for older people in care homes? Second, what is the magnitude of overheating risk in care homes in the UK? The third, what is the perception of overheating risk amongst care staff and residents in care homes who we need to protect? Do they understand this risk? Why do care homes overheat in the summer? We understand that they do, but why do? And to what extent can we adapt care homes using passive measures? So I'm going to run through the presentation, with these questions in mind, and then, show you how we can address, these questions. Just a little bit about us. So I run the Low Carbon Building Research Group and also the Oxford Institute for Sustainable Development in Oxford Brookes University. I'm also now the chair of the Sustainable and Resilient Futures Network in the university. And we have these core areas of research, and I'm going to focus on this one today, which is our area of work on climate change, resilience, and adaptation of buildings and neighborhoods. Within this area, we have a portfolio of research on climate resilience of care settings. I think we are one of the few research groups in the world who kind of research, in these settings. And I'm going to run through some of our research projects. We started doing this about 7 years back. where we started with the Joseph Rowntree funded project, looking at care provision fit for a future climate. We did 4 case studies across the UK. We then went on to do this pilot study funded by NERC, which is the Natural Environment Research Council in UK, Climate Resilience of Care Settings. We called it a pilot study because we looked at about 5 London-based care homes. And this was with UCL and LSHTM. And then the third project, which is ongoing, is also a NERC-funded project, but now extending the pilot study spatially and over time. So we have a nationwide study that we are doing, where we are recruiting 50 care homes. It's probably the definitive study on care homes in the UK. And we are also trying to do longitudinal monitoring. So not just one summer, but 3 summers. And so this is ongoing at the moment. It started last year, but stalled because of COVID, and now has restarted. So I'm going to run through these projects to answer the research questions that I've set up. So our portfolio of research really is focused on understanding the factors, which are both technical and social, which contribute to high indoor temperatures in care settings. We want to then develop strategies to avoid summertime overheating and look at negative health impacts, which are expected to intensify due to climate change. We've been fortunate to work with social scientists in this project, with health scientists. And we've been looking at in detail the comfort and also the health effects of overheating. So just addressing the first question is, why is summertime overheating a serious issue for older people in care homes? I think to understand that, we need to also look at why heat and older people matter. What is the link there? If we look at health evidence, it indicates that older people are particularly vulnerable to the effects of excessive heat. We also know there's a well-established relationship between high temperatures and increase in mortality, but especially in the elderly. This is evident because projections show that excess heat-related deaths per year in the UK could go up to about 7,000 from the current, I think, is around 2,000, and most of them are likely to happen among the elderly in poor health. But despite this growing evidence in the UK, there's the awareness of thermal risks, and especially the links with the vulnerabilities in older age, is still focused very much on the cold than on the heat. I'm not arguing that we should not focus on the cold side, but what I'm saying is that it needs to be balanced, and we need to look at both the winter period and the summer period to really adapt care homes. If we link this with the care sector, we know that the heat-related mortality during heat waves was highest amongst occupants of care homes, both residential and nursing. And this happened despite the presence of care staff that could protect vulnerable residents. The UK 2017 Climate Change Risk Assessment and the following National Adaptation Programme has identified summertime overheating as a major risk and health and research priority, both for the health and social care system. Our research was heavily cited, in these 2 documents. And we'd all know that the vulnerability of care settings, has been further exposed during COVID-19. So, again, this, alongside COVID, we also have the issue of, overheating. So it's kind of double problems that are going to happen. But despite all this, care homes have been designed, built, and operated with the aim of keeping residents comfortably warm. That's a key thing. They have to be kept warm all year round. There's very limited research on assessing the prevalence of summertime overheating risk in care settings. I think in the UK and internationally, I know there's some research happening in Australia also now, and Spain as well. So what are the risk factors, that affect this, risk of overheating? So if you kind of look at the location first, of course, if you're in a place like London, you're bound to get urban heat island effects. There's also regional and local variations. There are also issues with building design, obviously. You have high levels of thermal insulation and air tightness increasingly now because of other reasons, which minimize heat loss, but also kind of increase unwanted heat gains. The thing to note about care homes is that it's a hybrid building. This is not just a residential building. It's a workplace for some, it's a caring place. And you have these conflicting requirements sometimes of different actors who are inhabiting these buildings. There's obviously resident behaviors and practices. Older people we know are more sedentary. They spend more time indoors. They're also physically and mentally frail people. They are less able to adapt to short-term changes in environment. And their perception of risk and their own vulnerability is quite low. And then obviously there are the institutional care and management practices, where provision of warmth is perceived to be associated with good care. Adaptations can be enabled or constrained by management practices, norms and expectations, and the regulatory framework. I'll show how health and safety regulations sometimes conflict with adequate window opening, for example. And this came up recently in the media, where some of you might know, energy prices in UK have increased tremendously. And what this is in Guardian, where it was said that care homes, many of them could close down because of energy bills rises, because typical care home of let's say 50 residents spending around £50,000 annually on their energy costs and simply cannot cope up with rising energy bills. So we can't say that they're overheating, so let's put air conditioning, and cool them, because it's simply not cost effective and obviously not good for the environment as well. And older people, by the way, do not like air conditioning. They think they are draft producing machines. So whichever angle you look at, care homes are pretty vulnerable. So let's go on to the second question, which is, now that we know that there's certainly a risk, what is the magnitude of that risk in care homes? So I'll start with the first study. I'll quickly run through some of these slides to show you, what we found. This is the JRF study. This is the first study we looked at, which is, about 7 years back now. We looked at 4 care settings. We deliberately chose 2 care homes. And just for those of you who don't know what care home is, these are spaces which have single bedrooms with access to on-site services. And there were 2 of those, with 20 to 40 beds. And then we also looked at 2 extra care homes, and these are more independent. They are rented or purchased flats or bungalows, and they're designed for people with some level of mobility difficulties, and there's help and support available if there's an emergency. So we started off looking at these 4 care settings. There was very limited evidence at that time when we looked at this. We followed a mixed methods approach. So our approach, through this research has been socio-technical. We've looked at building surveys to find out, which design features are enabling or constraining, residents and staff to control their thermal environment. We've been monitoring environmental conditions. So, I'll start with 2015 and bring you up to 2021, and you'll see how, this problem has aggravated. We also looked at climate models. So we look at future weather data, 2030s, 50s, and 80s, using dynamic thermal simulation. We also did interviews with designers, development directors, the client, the scheme managers, carers, and residents. So you can see there are lots of actors involved, really to see how building design, management, and occupant practices address overheating risks and vulnerabilities. So we've kind of brought together surveys, monitoring, modeling, and interview techniques to kind of look at the prevalence of overheating. So this is showing from 2015, just plotting the indoor temperatures across all the 4 care settings. And you can see how high temperatures rise, they go up 30 degrees. These are, much higher than the Public Health England requirement or recommendation of keeping, spaces at 26 degrees or below. And this gets worse when there is a short-term heat wave. So in 2015, in July, there were 3 days which were very warm, or very hot actually. And you can see temperatures rise considerably then. And then we kind of looked at those temperatures against adaptive method and the static method as well, which kind of considers 26 degrees threshold and 28 degrees threshold. And whichever side you look at, overheating is happening in care homes, bedrooms, communal areas, offices, with different orientations. and different constructions. We then kind of wanted to see whether, this was just a one-off, or, whether, what does the models show? So we developed our dynamic thermal simulation models and looked at what the modeling would show in terms of the current risk. And interestingly, the same care homes, when you model with, calibrated, results, and you try to predict the risk of overheating, there's almost nothing. It's very low, and you can see how this is kind of not guiding designers properly. And as you go into 2030s, a bit of overheating starts to happen, but not much. In 2050s, a little bit again, not much, but 2080s, it really starts to show in models. Now, as compared to measured data, there's a very interesting comparison here. Look at what the measured data for 2015 is showing. Essentially saying overheating is a prevalent risk now, not in the future. And the reason for the discrepancy between models and monitoring is because models are assuming an average test reference year or a design summer year, which is not representing the short-term heat waves that happen and the extreme temperatures that can be experienced in a very short period of time. So clearly, those models need to be informed by what is happening empirically, and that's probably true for all sectors, not just care homes. We then published, the beauty about working with Joseph Rowntree Foundation was that they kind of taught us how to, not just publish for academics, which is obvious, with the journal papers, but how to publish for policymakers. And I worked with social scientists here, people like Gordon Walker, Alan Lewis, and we kind of had these reports come out along with briefings for policymakers. And that's how kind of this research informed the adaptation plan that I showed before. We then went on to kind of investigate that, that was a bit of a random study with 4 care settings and, very case study based approach, quite difficult to generalize from there. Although I expect, what is happening in those care settings is not different to what is happening in the stock. So we went on to kind of apply for this climate resilience program with the Natural Environment Research Councils. It's one of the research councils in the UK. And we did a pilot study called ClimateCare 1. There's a website here if you want more information, climatecare.org. This was funded by NERC. It was supported by Care Quality Commission. So this is the regulatory body for care homes in England, which kind of rates them. And this is very important because if they don't rate them properly, that will affect their operations and working. So this was a partnership between Oxford Brookes, UCL, and London School of Hygiene and Tropical Medicine. So we, really building physicists working with social scientists and health epidemiologists. And we undertook feasibility work by developing, novel methods, knowledge, and insights to really enable care provision in the UK to become resilient to heat stress. And we had environmental monitoring, thermal comfort surveys. So one of the things that was lacking in the JRR study is that we could not do resident and staff comfort surveys because of various practical reasons. But in the NERC study, I think we for the first time, we kind of managed to do this. We also undertook interviews, obviously, and did modeling for future overheating risks. And the LSTM also looked at health outcomes of overheating. These were the 5 kind of care homes we looked at in the pilot study. NERC, they're all deliberately located in London because we wanted to see, what's the effect in London. Is it different? Because previous study did not have any care home in London. So 2 of these care homes, the one here, PA, and this one, these 2 are older care buildings. So they are like 200 years old buildings. This is a very new building, 2013, and these 2 are mid kind of 1960s buildings. So we then kind of looked at all these care homes, together. So this is just the mean indoor temperatures. What is interesting is that previously you might have noticed that temperatures were going about 30 degrees. Now they're actually going up to 34 degrees in lounges and 39 degrees in bedrooms. They rarely fell below 22 degrees. This is now the summer.
Now you are on mute, so can you change? Okay. Again, can you change?
Yeah.
Now is okay.
Is it okay? Yeah.
Yeah,
So
now it's
essentially, we found that indoor temperatures rarely fell below 22 degrees, and bedroom temperatures were often hotter at night than during the day. And whichever overheating metric we use, whether it was the static guide A or the Public Health England threshold of 26 degrees, or the dynamic overheating metric, uh, overheating was occurring in all the care settings. Again, these were all care homes now, not extra care homes, and that is of course a matter of worry. We then kind of compared two care homes. We compared one older care home, so 200-year-old kind of care home, which was converted. It was Georgian and a house which was converted to a nursing care home, and a very new one, a very large and new one, kind of care homes built nowadays, I would say. This one was 115 residents. The one PA was 36 residents. They are almost co-located. They're in very similar location in West London. And we kind of went into detail about is there a difference between a care home which is very old, older building with of course thermal mass and some ventilation, and a newer care home. So when we look at the indoor temperatures of the older building, what is interesting is that the peaks in indoor temperatures corresponded to peaks in outdoor temperatures, but there was a bit of a lag, as you can see, and that slight lag, but not that much. And that's good in a way that it doesn't happen straight away, but it is still kind of overheated. But when outdoor temperatures fell, indoor temperatures also fell, but they were more gradual. And you can see, the mean temperatures across the bedrooms, lounges, and offices. So, the mean temperatures are about 26 degrees, and the maximum goes to about 34, approaching 35 almost. And the temperatures in the monitored space really remained, the mean remained between 24 to 27. And when we looked at the modern building, similar trend, but more severe. The peaks completely corresponded to when it got hot outside, it got hot inside. So when outdoor temperatures fell, indoor temperatures also fell gradually, but faster, in the modern VI building. And you can see one of the differences that the mean indoor temperatures in the modern building were higher. They stay around 27 degrees, which is pretty warm. And they even reach 32.5 in one bedroom. So essentially, overheating was happening in both care homes, but the severity was more in the modern building. And this is a very new building, to be honest. So what were the key findings of the monitoring? Overheating was definitely prevalent and prolonged. It was less severe in the older care home. The older heavyweight care home experienced lower mean temperatures, as I showed in bedrooms, both day and night, also in lounges and offices, than the newer care home. But what is interesting is warmest locations were bedrooms, where the least adaptation is happening probably. And one of the reasons it happens at nighttime is because they're occupied, doors and windows are closed. 99.9% times they have single-sided ventilation. Also, we found from the practices side that carers were spending more time in lounges than in bedrooms, and they were more likely to implement strategies for cooling when in the lounges rather than in the bedrooms. And that's also very interesting. So it's a mix of what's happening physically and also what's happening between people and the building, that interaction. And this is published now in a paper in the Building Services Engineering Research and Technology Journal. So essentially, the first study, the JRF fund showed that it was, happening, and this may be a risk. And then the NERC study showed that it was a risk, definitely, and worse as compared to, what we had in 2015-16. This is the project we are doing now. So I don't have lots of findings because we are still recruiting care homes and doing the study, but I still wanted to show you some very initial results. This again, as I said, it's continuing to 2023. Same partners, Brooks, UCL, and LSHTM. We're now trying to quantify this heat risks and care provision at a national level. So it's the go-to project now, really, for care homes. We kind of aspire to recruit 50 care homes across the country. We've already done 36, I think. So we are very much on our way. And we want to do longitudinal monitoring. That's again lacking. So the data that existed was, short-term monitoring in the summer. This does, hopefully complete 2 years or maybe 3 years of monitoring. Let's see how much we can kind of get in. We want to assess the impact of heat exposure on the health of residents. So doing very detailed measurements by health epidemiologists, doing core body temperatures and seeing the relationship of that with heat waves, and develop a building stock model of the care sector, really, of care homes, which is currently lacking in the UK. So we feel 50 care homes will give us that strength to do so. I'm giving very initial results. This is from September because we were only allowed to go in from September. And just to be clear, it's a very challenging sector to work in. And care homes in UK operate in a way how we were, when lockdown started. So there's a lot of strictness, a lot of testing to be done. And it's challenging to get into spaces now. So we started last month in terms of our field work, and I'm showing very initial results, really. And this is the gray line is showing you the temperature. So, you can see even in early September, which is officially the end of summer in UK, temperatures are exceeding 28 degrees, and maximum temperature recorded has been just under 30 degrees. So clearly it is a problem. I don't know what is happening, next summer, but the loggers that we have now installed are remote, they're Bluetooth enabled, they're internet enabled. So we don't need to get into these care homes. We can get the information remotely, and they hopefully will be monitored for at least 2 years, if not more. The relative humidity we found is very low. That's probably because, there's limited ventilation happening. And I guess when heating starts or has started, this is going to be much lower as well. And that also causes problems, as you know, with older people and generally with everybody. 25% or below humidity will cause, dryness of skin and other things. So essentially what I'm saying is that, from a case study based approach to a focused pilot study to a nationwide study, we are seeing this as a problem, and the magnitude is getting established, day by day. But then the other bit is the people, the physical measurements are showing that definitely there are elevated temperatures. There's, whichever criteria you use for overheating risk assessment, it is happening. But then what is the perception of overheating risk amongst care staff and residents in care homes? And I must say that when we started this, there was almost no evidence on this, in terms of comfort perceptions of people. So we looked at both residents and staff, and this is just over 650 responses from the 5 care homes. This is from the NERC pilot study. And essentially, the red ones show residents and the blue are staff. And as you can see, it's very obvious that residents are more likely to vote for neutral thermal sensation. Staff are much more likely to vote for hot thermal sensation than residents. And the votes for neutral, warm, and hot thermal sensation are occurring at significantly lower concurrent black globe temperatures for staff than residents. So essentially, residents are pretty insensitive to heat, which is a bigger issue as well, which means some external intervention is necessary because the older people don't realize when the threshold gets crossed. And you can have very serious health implications if your core body temperature rises quite a bit because you're in a very heated or hot space. And staff, on the other hand, are feeling hot at a much lower temperatures because they're working all the time, and the older people are more sedentary. And you can see this is across the 2 care settings that I was talking about. The PA is the older one, the VI is the newer one. And you can see that when you look at the black globe temperatures against the thermal sensation votes, there's disparity between indoor temperatures that staff consider hot. So again, look at the difference. Staff are feeling hot at much lower temperatures, residents at higher temperatures. And this is very much clear here. The newer one, the difference is slightly less. And the median temperature when staff described themselves as feeling hot was around 29 degrees. And for residents, it was 32 degrees. So clearly some external intervention is necessary because residents are seemingly insensitive to heat. When we ask staff actually that, obviously you're feeling hot and, how do you cope up with it? The view is that it's their home, it's a resident's home, so it's our working place and we have to put up with it. But I think there's, health and well-being issues here, both for staff and residents. So what did we find, from the thermal comfort surveys? Both residents and staff in modern care home were less satisfied with their thermal conditions than their counterparts. That was kind of obvious. There was large disparity across all 5 care home settings between thermal sensation of residents and staff. Residents rated their thermal sensation as neutral even at temperatures of 32 degrees, and staff members were twice as likely as residents to rate thermal sensation as warm or hot. And probable reasons, as I said, was because of the difference in activity, obviously between passive residents and active staff. Of course, elderly people also have lower metabolic rates. So, that's kind of disparity can be explained, but certainly needs to be addressed. Then the fourth one, the fourth research question that I want to look at is, we've shown that there is the magnitude of, the risk is high, overheating is prevalent, it's prolonged. The perception of overheating is mixed amongst residents and staff. The question really is, why do they overheat? In the first place, why are these care homes overheating? And there's some very interesting findings here, and I'm taking across the projects now. First, I think there's this culture of keeping older people warm, because there's this perception that older people are vulnerable to cold, not heat. And I think that needs to be challenged. And this perception is completely ingrained from designers of care homes to frontline staff. And that is a big problem in itself. While cold seems to represent, of course, a bigger threat, there is less recognition that heat can also present a significant health risk. There are, of course, conflicts with health and safety requirements where window restrictors are put in, because there is a fear that older people might fall. I've never figured out how many people have actually fallen through the windows. Try to ask CQC, because I think this is one of the rules that might need a bit of investigation and consideration. But they only open about 10 centimeters, which is not enough if you have a heat wave. And there's low prioritization of overheating and future climate change amongst the briefing and the design teams, because they think it is not a risk of present, it's a risk of future. There's lack of effective heat management practices. There's lack of investment in physical strategies, because that's not what is happening. Shading, for example, external shading should be designed in, so you keep the summer sun out and the winter sun in. There's conflict between passive cooling strategies and occupant requirements. So you can't simply say, let's put the curtains on because it's quite warm, because the older people want to have a view out, and that kind of takes precedence over, drawing the curtains. The centralized heating in hot water systems lead to unwanted heat gains, because the pipework is usually not insulated and the heating stays on even in the summer. So you can have very hot corridors. There's separation of roles within the care organization, which creates confusion in terms of responsibilities. So nobody knows who's going to switch off the heating system, who's going to manage the thermostats, who's going to manage the indoor temperatures. And that needs a bit of kind of rethinking. There's lack of awareness about the heat wave plan as well, which was not a pleasant find, because Public Health England in UK does give all that guidance. But right from the design briefs, the priority was on other issues, safety, security, and I've already told about window restrictors. Managers were aware of the Public Health England heat wave plan, but the care staff, the frontline care staff, were not that much aware. The aspects of the plan that were implemented were very ad hoc. They were, pushing fluids, providing electric fans. There was hardly any consultation with the resident GPs about health risks. And this is worrying, because, some of them are on medication, and it's important to kind of, maintain that link with health professionals. Public Health England suggests providing one cool room which has temperature below 26 degrees within each care home in case of a heat wave. But practically, there's a lack of suitable rooms, within care homes. You can't just have a space like that. Also, it's impractical to move all occupants in one room, because some of them might be bedbound, and it's simply not possible. So I'm not sure if this is actually practically being implemented. And then there are also ingrained practices of residence, which can be a barrier during heat waves. So, having hot meals, continuing to do that during heat waves, not changing your clothing ensembles, not doing frequent washing. So there are these kind of practices also that kind of aggravate that risk. But then the final question is, to what extent can we adapt care homes? We know there's a problem. We know, there's difference in perception of it. We also know why they overheat. It's a combination of reasons of, physical and social and practices as well. But what can we do, or can we do something using passive measures? I'm obviously going to, lobby for passive measures rather than going for active measures. But there are, in our kind of suite of measures, there are quite a few. You can manage heat, you can look at insulation level, look at external surface albedo, have window solar protection, look at thermal mass, ventilation regimes, look at green-blue infrastructure, maybe fans where necessary. But then what did the models show, and what is the reality? Because I think I'm always kind of looking at the difference between what modeling tells us and what the reality is, because frequently they're not same, as we know. So this is a paper we recently, well, not recently, this is the older paper which we published through JRF study, and we got a recent paper as well, which is kind of confirming the same thing. But the modeling results confirmed that there was a need to implement long-term adaptation approaches, and they were looking at, really external shading and cross ventilation, which is quite hard. And, because of the pandemic and other reasons, cross ventilation is really important now. So I would say that that's the single important measure that we should look at for care settings. The interviews with designers showed little awareness amongst designers about the risk of overheating, and they really focused on now, the current situation rather than long-term planning. And remember, these buildings, once they are built, will last for 50 or 100 years. So we are almost compiling problems for future by not having enough design for overheating mitigation happening. The recent paper that I was saying from the NERC study reconfirmed it. This has just appeared in Energy in Buildings, so you can have a look. This showed that our simulations found that nighttime ventilation again was the single most effective passive solution up to 2050s actually. So a combination of nighttime ventilation, external shading, and high albedo external walls, we found from a modeling point, could kind of provide resilience up to 2050s against the overheating risk. So simple measures, quite difficult. I say simple, but they're not done. So I wouldn't say they are simple. But what happens in reality? This is what the models tell us. But in reality, yes, 1 out of our 5 care homes had some shading, but that's just 1 or possibly 2. But then there are passive measures or physical measures that actually exacerbate the risk. For an example, you have single aspect resident rooms. Dual aspect is only present in communal areas. The centralized heating with pipework runs throughout corridors, causing overheating. Health and safety requirement, conflicts. So window restrictors, as I said, low level TRVs. So, often, older people and even staff don't kind of, manage their own heating. And interestingly, trickle vents, when present, are either closed or painted over. So there's very little awareness about what trickle vents are doing. They're quite important to actually have background ventilation, but almost 99% of times they are closed or painted over. So, the models might say that these things are necessary and worth doing, but in reality, either they are not done, and if they are done, then they may not be managed in the way our models assume they are managed. So there's a big kind of disparity between this. So I think I'm going to end with some points for discussion, because I think we have some time for discussion. So I'm going to kind of raise these, and hopefully we can have a discussion on this. So it's very obvious, whether it was a JRF study or the NERC pilot study or the ongoing nationwide study of summertime overheating in care settings. Overheating in care homes is prolonged, severe, and prevalent. And worryingly, residents are insensitive to high temperatures. So that certainly needs to be looked at, because there are health implications of your core body temperatures rising quickly and substantially. Design for overheating was not found to be commonplace. This is worrying. And my question really is, how can innovative design solutions for tackling overheating become widespread? Maybe this is something that needs to be tackled from schools of architecture, engineering, going up to continued professional development, into design practices. And how do we get this culture of making a design for overheating mitigation commonplace? Then we must now, given the power we have with IoT and with smart sensors, we must regularly monitor both indoor-outdoor temperatures in care settings and provide rapid feedback to management, care staff, and residents. So my question really is related to that. What is the role of smart sensors and surveys in identifying overheating rapidly and supporting timely action? Because you'd be surprised, but none of the care settings we went to had any monitoring happening. They had BMS, but as you would expect, not working properly or not used properly. And there is a bigger question here, that how can we do smart monitoring and actions as a result of that monitoring to manage the risk of overheating. And then I'd say finally, how do we, the bigger question, how do we stimulate a culture change within the care sector? We've been very fortunate that in the NERC nationwide study and the pilot study, we worked with Care Quality Commission, who are partners in the project, and they've been hugely supportive in terms of recruitment, in terms of taking on board our feedback and recommendations. And really the question really is how Department of Health and regulators can integrate these criteria on preparedness for tackling overheating into inspection procedures. Things are happening. I understand that CQC has put in now procedures for looking at indoor temperatures, but there is still no maximum requirement that the temperatures cannot go above. And so how do we get this preparedness for tackling overheating into care sector policies and inspection procedures, because that will probably change the tide. And thank you for your attention. I couldn't have done this work without our research team from Oxford Brookes, University College London, and London School of Hygiene and Tropical Medicine. And I'm going to stop here. Thank you, everybody.
Okay, thank you very much for your presentation. So we have a few questions for you. So at first, I'd like to introduce Dr. Salis Al. So he's asking, I'm not sure if you have compared the simulation result of the overheating from the year 2015 and compare with the actual measurement of the year 2015. In addition of the using TMY or TRY, I think also the discrepancy between the dynamic models and actual measurement is due to the calibration methodology. If the temperature is to be analyzed, then the indoor temperature predicted by the model should be calibrated. So could you please respond? Yes, shortly. Maybe we have many questions. So
okay,
yeah.
I'll be brief. So the short answer is yes, we did compare. So we compared the current current measurement that we had with the models for the current climate. So there were discrepancies, obviously, and we calibrated them, which is what I showed in one of the slides. And the reason is because the models are using past weather data. It's nothing wrong about it. It's just how these models are developed. And they don't look at short-term heat waves. I understand that CFC is now doing work and have weather files which can look at some of these short-term heat waves, but at the time we were doing it, they weren't. But yes, they are all models were calibrated for because we had all the details from our empirical results. So yes.
So I'd like to have one more question from Surov. So what do you imagine the main outcomes of this excellent project will be?
Okay, so I think, thanks for the question. The main outcome for this has been that we've managed to change the guidance from Public Health England that is sent to the care sector. So we developed with the Public Health England personnel a checklist for managing overheating risk in care homes. And this is designed for the care staff and managers. And that has been sent to all the care homes. It's been downloaded, I know, thousands of times, and that's being used. The second bit I think we have managed to influence is working with Care Quality Commission to really consider indoor temperature monitoring as one of within their health and safety aspects of their inspection regimes. More could be done, I would say, but those are important. With the designers, we've had a lot of sessions in terms of what can be done for overheating, but again there's some work to do there. So yes, I think we have managed to influence policy quite a bit through this.
Okay, so please respond slightly quickly. We have so many questions, so we like to take all. So one more question from the Mission Sister: are care homes friendly to older people in UK? Have you found any cases, evidence during the survey where older occupants living in the care home died due to the overheating?
It's very difficult to establish that link. I know why you're asking, but it's very difficult. We've tried to do that to look at the deaths that occurred during the heat wave or just after that. But it's very difficult to attribute that. In terms of the care provision, I can say that, yes, they're looked after. I don't think that's an issue. I think the issue here is whether the staff who are looking after are aware of the link between elevated temperatures and health effects. I think that's where the issue is. It's not that they're not providing the care, it's whether those carers have that link established. No, and the answer is it's very hard to find. I'm sure there is a link, but it's not easy to find.
Okay, thank you. So I'd like to have one more question. So what do Magaya Nitu, and what do the death rate of the elderly in the UK says, Professor? It is higher during the summer than compared to the winter. So I think she's asking about the death rate. So okay. Summer is higher or winter is higher in UK? No,
still I would say in UK you have excess winter deaths as obviously being higher than excess summer deaths. But the excess summer deaths are increasing and cannot be ignored. So yes, you would say it is there, but remember we are not measuring the excess summer deaths that much. And once you start doing that, things will change. Just to let you know, there was a study done, I think by WSP in London homes, not care homes, and 83% of all homes in London overheated in the summer. So this is a pretty widespread risk, I would say.
Okay, so one more question from the mission. So as you present, care houses is in the UK need to be comfortable all year round. So what are your findings on such buildings' energy use pattern? So if you'd like to know about energy use.
Yeah, I think it's a good question, Mission. Firstly, in this current project, we are extending the monitoring to look at summertime and wintertime, because we believe that there is wintertime overheating happening as well, not just summertime. And obviously all that has energy implications. As I said, the energy costs are very high in care homes. Even a 50-bed care home is about £50,000. And as energy prices are increasing in the UK, many of them are at the risk of closing down. So yes, we are measuring energy use now in all the care homes that we are studying, and it's pretty high. And remember, if you are providing excessive heat, whether it's during winter or summer, you are adding to the energy load. So yes, definitely, we are looking at all year round now, not just the summer.
Okay, so I think there is no more question in the chat box. So, but I think they may still coming. So I just like to ask a few questions to you.
Yeah.
So I think the definition of the overheating is over 26 degrees. Is this right?
So from Public Health England, not from me. Public Health England in the UK is saying that. Yes.
Okay. So you mean you are saying the percentage of overheating is the temperature which is more than greater than the 26 degrees. Is that okay?
essentially they are saying, Public Health England says that you have to keep the temperatures below 26 degrees, at least in one place. It is not my definition. It is just something that the care sector has to follow.
So my another question and comment is about perception of the overheating. So you said the staff feel more hot than the resident, right?
Yeah.
So maybe I think it should be very careful, because maybe staff is moving and maybe they are not adapting in their other people's house, but in the residents, their own home, maybe they are more adapting in their own houses, right? So I think we need to be careful. So how do you think about that?
Yes. See, I think you're right, Hom, that staff are certainly feeling hotter and they are not adapting that much because it's their workplace. And in a workplace, they're just moving around and caring for people. The staff the residents, I'm not sure are adapting to, because, they are more sedentary, passive, and probably, not moving that much, which is why they are feeling less hot and are being insensitive to heat. So yes, there is this combination. And if residents could adapt more, then certainly, it would be good from a health side as well, because their core body temperatures are quite high, with the limited measurements that we have. But staff definitely, and I think the worrying thing here is that the staff are willing to put up with it because it's not their home, and that's not good for their own well-being. And I think what we need to see care homes that they are hybrid buildings. They're not just residential, they're not residential only, they're offices, they're lounges. And I think that when these are designed and managed, we need to look at that aspect as well.
So my another comment to you is you have analyzed the thermal sensation board, right? But I think you also need to make a detailed analysis. So for in what temperature they are responding, whether they're hot or maybe they're neutral, right? So I mean, you have to do some of the regression analysis and have to find some detailed relationship in between the temperature and the response. Yeah.
Yes.
Have you done that kind of analysis or not?
Yes. So that's been published. If you look at the papers that I've been alluding to, also in one of the slides, I showed you the relationship between the temperatures and the thermal sensation. And as I said, residents are saying they're neutral at a much higher temperatures than what staff are saying. And yes, all that analysis has been done and is now published.
Okay, thank you. So I have one more question from the Sue. So there is a good research showing that thermal variety is important for the physiological health of the older people. Is the UK guidance taking account of this?
So the honest answer is no. I don't think the guidance really looks at that thermal variety. I think if you look at the guidance that's out there at the moment, it's 26 degrees. I don't know how that's come about and what's the science behind the 26. I expect it's one of the papers by Fergus or Mike Humphreys that's been used, but essentially that's what it is. At the moment it's 26 degrees that they kind of look at, and much more work can be done. I absolutely agree with you. I think there's also underutilization of semi-outdoor spaces, and how they could be used for adaptation purposes as well in the summer. So there's a lot that can be done in terms of guidance and recommendations, and that's one of the things we want to address through the larger project that is ongoing, because Public Health England is one of we have one of them as the officials is a co-investigator in the project, interestingly, and Care Quality Commission is helping us with the recruitment. So we have the ears of the organizations who can make a difference. So hopefully some of that guidance can change with the findings of the project.
Okay, so I have one more question to you. I think it's Mohammed. So as understood, passive ventilation strategy were not fully utilized. Could you please elaborate on why windows or fan were not fully utilized to overcome overheating of the spaces?
Yeah, it's a really good question. And, I'll answer it in two parts. First is, windows. They were not utilized for various reasons. First, it's single-sided ventilation. It only opens 10 centimeters, and the care staff are always worried that older people will fall through the window. So, the windows are really either kept shut or open in a very limited way. And I think the issue needs to be addressed in terms of awareness, training, and management. This is, and also through design. As I said, I'm trying to still find out how many people have actually fallen through those windows to have this 10 centimeter. And you can, by design, have windows which can still open enough, but can still be safe. I don't think but this is the issue that, and how can we get more cross ventilation in these spaces? Why fans were not utilized? I think that's because of the perception of older people. I don't know if you've ever kind of spoken to older people. They find anything that produces air is drafty because they haven't been brought up with fans and cooling devices in UK. So it's very uncommon, and they don't like it. So it's also that acceptance of fans, and it's used. I wouldn't say it's not used, but it's not used enough, I think. And more could be done. We did see one room which was air conditioned, and I did ask the occupant there, what their perception was, and they said, I don't like it. It's just too cold, and it produces draft all the time. And so it's not, I think to address this issue, building design and natural ventilation strategy should be prioritized over mechanical ventilation, because they will be much more acceptable to the older population rather than these. I don't think. And also, as we move towards active cooling, it will have an energy penalty, and care homes in the UK are on a knife edge. You don't push them towards higher bills because they might close as well. So
okay, so I think I took all of the questions. So as you see, the temperature is increasing, so in all over the whole, isn't it? So based on this adaptive principle, if they used to live in the high temperature, maybe the adaptation also increase. For example, if the cold climate, they always live in the lower temperature, and their comfort temperature also low in compared to the hot climate, right? So how do you think, for example, if the temperature is increasing, maybe in the UK, the people also, they adapt to live in the high temperature. So maybe the 26 degree, if we think in Japan, is the level is too low in compared to Japan, or some of the, like in Pakistan, maybe some of the cities in India, because they used to live in high temperature, right? So maybe in UK also, maybe they also need to increase that limitation, or maybe in the future, because the British people also, they used to live in the high temperature, and also they will adapt to the higher temperature. So how do you think maybe in the 2050 or 2080, maybe how we have the standard or the adaptation goes?
Yeah. No, I think it's a good question. Remember what Fergus always says is that you can adapt yourself to the building, or you can adapt the building to yourself. And I think what is going to probably happen is the people might adapt to the building. I'm not sure how much they could adapt the building to themselves, because there are a lot of constraints there in building design. And I think both have to happen for the reasons you are saying, that we have to, of course, increase that threshold, but also we have to be mindful of that these are frail elderly people. We have to be managing the health bit as well. So provided we kind of are able to help people in adapting the building to themselves, yes, definitely, we can increase the threshold where necessary.
Okay, thank you very much. I think we have almost time, so 1 hour. Okay, thank you very much for your very nice presentation, and I think we learned a lot. Okay, thank you very much.
Thank you very much. Bye.
Okay.